A good evening, rather, to all of you. And welcome once again to the teaching session of Department of Urology, Savai Mansingh Medical College, Jaipur. So today we have a faculty talk on Aerodynamics, back to basics. So this talk will be given by our faculty, Dr. Arvind Ganpelay. Dr. Arvind Ganpelay is a consultant urologist at Mulji Bhai Nadiad Hospital. He is quite known in the academic circle. He has more than 180 publications, a lot of book chapters, edited 6 books. He has contributed chapters even in the Bible of Urology, which is Campbell's Urology, Hinman's Atlas of Urology, Smith's Textbook of Endourology. He has also 2 patents filed up. And he's the associate editor of the Indian Journal of Urology and also in the editorial board of World Journal of Urology. So, he has received many awards, including the Best National Reviewer, Best Reviewer, and Outstanding Alumnus. So welcome, Dr. Arvind Ganpelay, to our teaching session. Thank you for joining us today. And I would now request you to start your presentation.
Thank you very much, Shivam sir. I must say that I am indeed honored and privileged to be here giving a talk in this in front of this august gathering and in front of the residents of this esteemed institute. I have been charged with the duty of talking something about Aerodynamics, and as I was just discussing with sir, that this would be a very timely talk because we'll be going back to the basics, and as you'll be getting the new machine, I think all of you will be interested in this topic. So over the next, say, 45 minutes, I have decided to divide my talk along the following lines. As we are going to talk about basics, I thought that I'll talk something about the physiology of normal micturition, which is, I think, very relevant to the topic of Aerodynamics. Then we come actually to the crux of the matter, as to we'll be talking about Aerodynamics, as to what is Aerodynamics, why should it be done, when should it be done, and how should it be done. We'll talk about the invasive and non-invasive part, and when we say non-invasive, what do we mean by non-invasive? And finally, a few case studies, and if somebody wants to volunteer and come ahead and answer the questions, I think it would be very interactive. And finally, I would like to take any questions, if any, before we conclude the session. So let's talk about a few definitions. Many a times in exams, the exit exams, the candidate many a times mentions the word neurogenic bladder. I feel that we have to really understand what we mean by a neurogenic bladder. So there is a difference in neurogenic bladder dysfunction and neurogenic bladder. Neurogenic bladder dysfunction sometimes simply refers to a neurogenic bladder and is a dysfunction of the urinary bladder due to diseases of the central nervous system or peripheral nerves involved in the control of micturition, that is urination. So one has to remember that whenever one labels a patient to be having a neurogenic bladder, you should have some discernible cause which can be attributed to the bladder dysfunction. So all neurogenic bladders usually cause difficulty or full inability to pass urine without the use of catheter or any other method. So these are the few prerequisites you should always keep in mind, that always see for something neurological before you label that patient to be a neurogenic bladder. Say in sacral agenesis, suppose and spina bifida, history of surgery, something should be there before we label him as a neurogenic bladder. Otherwise, it's very likely that the patient might be a non-neurogenic bladder and we are labeling as in a neurogenic bladder. We'll see what are the implications of this definition. It's not just a theoretical discussion, but it has got some amount of practical implications as well. So this is a very nice picture which I came across. Actually, all credit goes to Dr. Anita Patel, who is a faculty here. And this was a picture which I just borrowed from her. So this is the happy family. You can see that there is no hydronephrosis, no dilated ureters. The bladder is not thick-walled, no bladdernic hypertrophy. And this is the unhappy family due to a neurogenic bladder. You can see that there is hydronephrosis, hydroureter. You can also see that there is some amount of bladdernic hypertrophy. So what we conclude from this schematic drawing is that we realize that for any renal system, bladder is the master of the family. So we have to always take care of the bladder if you want to prevent deterioration of the renal function later on in the course of the disease. We further go along the discussion of the physiology or act of micturition. We all know that there are 3 events whenever one passes urine. The first event is relaxation of the external sphincter, and this is a somatic event. The second event is a detrusor contraction. The third event is the bladder neck opens. At this point, urination is urgent and it's almost impossible to stop urination. So the urination can be stopped till the second event is initiated. What one has to remember from these 3 events is that passive continence entirely depends on the internal sphincter, that is the bladder neck, and not on the external sphincter. And active continence largely rests on the external sphincter, and hence you will see that most of the post-URB patients are continent, provided the external sphincter is not iatrogenically damaged during the procedure, in spite of the fact that we are damaging the bladder neck, because that is responsible for the passive continence. Similarly, when we are doing an RARP, say an radical prostatectomy, we are actually dealing with the external sphincter. So that is the reason that we give importance to an long urethra. We give an importance to an properly reconstructed bladder neck. We give importance to the Kegel's exercises because we want to strengthen or preserve the external sphincter. So the bottom line of this slide is that these are the 3 events of the act of micturition, and we have to remember that all events should be synergistic, they should be synchronous, and they should be coordinated. If all these 3 things are there, then it's very unlikely that the patient will be having a neurogenic or a non-neurogenic bladder. The same thing can be depicted in this very beautiful schematic drawing, wherein it shows what are the external sphincter EMG tracings you will see whenever you have attached an EMG probe in the process or in the event of voiding, that is during the physiology of micturition. So you see that whenever the external sphincter is closed, there is a lot of activity on the EMG. But whenever the sphincter opens up and the bladder neck contracts, it should be silent. So just to remember that whenever there is DSP, actually there should be a complete silence whenever the patient is passing urine, but here there is a lot of activity. So one thing that you have to remember is you can just have a mental picture of what you are seeing in this particular thing to understand the activity of external sphincter on EMG. Something about this thing which we all are learning since our physiology days, and it's quite confusing. Let me concede to this fact that what are sympathetic nerves, what are parasympathetic nerves, what is LMN, what is UMN, and all those things. But let's try to make it as simple as possible. So storage means sympathetic and parasympathetic means peeing. So this mnemonic was also told to us when we were in our first MBBS days by the physiology professor that sympathetic nerves, that is from T10 to L2, are responsible for the storage function of the bladder, while for the peeing or while for the process of passing urine, the parasympathetic nerves are involved, and the segments that are involved are segment 2, 3, and 4. A little bit, let's dive a little bit more into the details. So the autonomic control, that is the sympathetic control for storage, is from T10 to L2, while the parasympathetic control for peeing is from S2, 3, 4. So together these form the pelvic plexus. So there is a boss for both these things beyond them, and the boss is the center of coordination, that is the pons, and the frontal lobe for permissive role. So unless the signal goes and there is no clearance from the frontal lobe, in spite of the fact that there is a contraction of the detrusor, the patient is not going to pass urine. Similarly, voluntary control is mainly through the sacral somatic component. So the voluntary control, that is the S2, 3, 4, keeps the external sphincter contracted, and that helps in preventing passage of urine whenever it is not convenient to pass urine. Unusually to have a neurogenic voiding dysfunction without a bowel involvement. So now this statement is very important, and the reason is that most of the bowel involvement occurs because of all these 3 sympathetic nerves and the parasympathetic nerves. So one of the important point that you need to ask in the history during the examination whenever you are suspecting a neurogenic bladder is whether the patient is having any bowel involvement or bowel dysfunction. That may give an indication that actually the patient is having a neurogenic bladder. As I told in the last slide, that that sphincter should be synergic, the sphincter should be coordinated, and if it is not there, as we saw in the EMG diagram in the slide previous to that, it may account to be the patient may be accounted to be having an DSD, that is detrusor sphincter dyssynergia. So the take-home message from this slide is that S, that is sympathetic, is for storage, and P, that is parasympathetic, is for peeing. Again, as they say, surgical anatomy. Here we have got surgical physiology, because we surgeons use very few drugs. Out of them, the majority are these antimuscarinics from M1 to M5. Most commonly occurring are M2. The drugs that we are using are oxybutynin, tolterodine, and sulfenazine, and which are more bladder specific. Nowadays, the brand names are coming, but the generic name is darifenacin, that is M3. So you can now correlate what we saw in the previous slide, wherein we say that S is for storage and P is for peeing, and you can see why we are using these drugs. Similarly, the alpha blockers, the second group of drugs which commonly the urologists use, they are mainly at the alpha receptors are mainly at the bladder neck and the prostatic capsule, and their action is stimulatory. So whenever we give alpha blockers, they have got a relaxing effect, and then naturally the patient passes urine in a better way. Now coming and delving a little bit more detail before we go on to the actual crux of the matter, what is expected from a bladder? What is expected from a normal bladder? What is the function of the bladder? The bladder is expected to store urine at low pressure with no leak on postural changes, physical or mental stress. Bladder must give awareness signals of progressive fullness, which typically occurs around the bladder volume of approximately 150 ml. The bladder should have an ability to understand when the bladder is overdistended. The bladder should have an capability to empty at low pressures without transmitting the pressures to the upper tract. The bladder should have an ability to void irrespective of bladder volume at will whenever it is convenient to pass urine. So these are the attributes of a normal bladder. Anytime a bladder deviates from these 5 attributes, it might be accounted to either non-neurogenic or neurogenic bladder. So how do patients with bladder dysfunction present? I have taken a few examples and the commonest presentations how they present. Like first, diabetes. The commonest presentation of an diabetic cystopathy would be an underactive detrusor. Very unfrequently, we can see overactivity. The commonest urodynamic finding in a diabetic patient, which is particularly uncontrolled, is underactive detrusor. We'll compare what an CVA patient with a stroke. I'm not talking or going into the details of LMN or UMN, but I'm talking about a CVA patient. Most commonly, a patient with stroke will present with bladder symptoms of overactivity or DSD. DSD is slightly uncommon as compared to Parkinson's. In Parkinson's patient, the patient presents with 2 important things, that is overactivity, and it's very likely that you might confuse an Parkinson's patient symptoms for bladder outlet obstruction. So that is one very important reason that whenever a patient presents with bladder outlet obstruction and has got a history of Parkinson's, you have to be very careful before you advise him to URP. This is the reason for it, because most of the patients will present with DSD or sphincter dyskinesia. Finally, how do commonly a spinal cord injury patients present? They commonly present with renal deterioration. You see that most of the patients will present to you late because those poor patients really don't realize when the upper tract gets fired. Most commonly because of the poor compliance of the bladder, that the bladder becomes very poorly compliant and the same pressures are transmitted to the upper tract. Before we go to the urodynamics, we have to understand that which are those patients who actually require urodynamics. Urodynamics should be chosen very judiciously. It's not so that you can choose urodynamics in all the patients. You have to know the clear-cut indications wherein you are going to do the urodynamics and how do you elicit the history. I would say that this is one of the tools which is actually very underestimated, that is the IPSS. And I must say that IPSS with the QOL, not just the means, if it is just the 7 symptoms, it's called as the AUA symptom score. But if the IPSS, the 7 symptoms are combined with the QOL score, it is called as the IPSS score. You all will agree with me that whenever you give an IPSS score to the patient, most of the times you will realize that patients are not in a position to interpret or discern in between these 5 columns. They get confused, and that's the reason why we don't get a proper IPSS score. In fact, we did a small study at our center wherein we found that the inter-subject variation was minimal when we compared the number 7 score, that is nocturia. We found that there was a lot of correlation in between what the clinician wanted and what the patient actually had in the number 7 symptom, that is the nocturia, because it is very objective, not subjective. Probably because of this particular drawback of the IPSS score, all of you must be knowing this paper, which is published in the Indian Journal of Urology from Manipal. Our honorary secretary, Dr. Lakshman Prabhu, is the author of this paper, wherein they have come out with this paper with this terminology, which is called as VPSS, means Visual Prostate Symptom Score, wherein they have given this sort of schematic diagrams or drawing, wherein they have elicited the 7 symptoms of the IPSS score. So in this way, the patients can interpret their symptoms and actually put forth what they want to say to the clinician. So the symptomatology of any neurovascular dysfunction is either obstructive symptoms, irritative symptoms, mainly frequency, urgency, and as we just discussed in the physiology of micturition, they most of the times might present with bowel complaints, that is constipation. As I'm repeatedly saying in the past 10-15 minutes, that always rule out or always confirm whether the patient is having a non-neurogenic neurogenic bladder, and just don't label the patient a neurogenic bladder when you don't find any neurological disorder with the patient. This is also one of the most important tools, which I feel that it gives a wealth of information if you give it to the patient, and the patient is in a position to understand what we want to say. Just to give you an example, this is a frequency volume chart, also called as the voiding diary. You can see that these are 2 patients who are presented with frequency and urgency. The symptoms are same, but if you see that the amount of fluid that this number 1 patient is consuming is approximately 6,350 ml. And every time the patient is voiding, say, around 200 ml, 250 ml. But you come on this side. On this side, you see that the patient has consumed just 1,650 ml. And every time the patient is passing just 50 ml, 60 ml, 20 ml. So you see that you have cleansed the diagnosis. You have also understood that what the patient is having. Like on the left-hand side, the patient is a compulsive drinker. His bladder is of maybe a little bit a larger capacity. You see that he has filled approximately 500 ml at one point. While on the other side, you see that the patient is having a small capacity bladder, most likely. So you can differentiate using this very simple tool, whether what is the diagnosis of the patient. Both the patients are having the same symptoms. And very important examination finding when you want to rule out or confirm the presence of neurogenic bladder is the Pulpo-Cavernous reflex. So the Pulpo-Cavernous reflex tests the integrity of the peripheral neurologic control of the lower urinary tract. This reflex is elicited by stimulation of the glans penis in men or clitoris in women, which causes contraction of the external sphincter or the bulbocavernosus muscle. So when this is there, you can be assured that there is an integrity of the peripheral neurological control of the LUT. Alternatively, if this is not there, the reflex may be stimulated by pulling the balloon of a Foley catheter against the bladder neck. And this reflex, one has to remember, is present in all normal men and in approximately 70% of normal women. And absence of this reflex is strongly suggestive of an neurological lesion. So you can understand the importance of eliciting and the importance of examining the patient for the BCR reflex. Going further, sometimes they refer to this as a non-invasive urodynamic test because it's very simple, can be an office test, does not require any expertise, and gives a wealth of information. Actually, it helps us in clinching the diagnosis just at seeing the graph. We'll go into the details and understand the small but interesting nitty-gritties of this simple investigation. So anyone with lower urinary tract symptoms meriting further evaluation requires a flowmetry. In fact, as we all agree, it should be a part of our OPD evaluation. You see that even though if you go for CAMS, we always take the uroflowmetry with us because it's very simple. Apart from this, we also have to remember that just seeing the graph doesn't help. We have to see the graph and see how much amount of post-void residue is there, because we sometimes see reports wherein we see the uroflowmetry graph, but the post-void residue is not mentioned. So both are very important in giving a final interpretation of the findings. A bit of theory and what is asked in the exam. These are the two commonly used type of uroflowmeters, the rotating disc and the load cell. One is gravity dependent, one is non-gravity dependent. A few important practical tips which actually you have to tell the patient when you have advised an uroflowmetry test. The minimal volume of the urine that should be voided for any uroflowmetry is at least 150 ml, as that is when most of the adults feel physiological desire to void. And at 150 ml, most of the times, if it is not in small capacity bladder, they are not bursting full. So the results which actually mimic what actually the patient is, what symptoms the patient is having. The patient should report a desire to void and should admit that the test that he performed mimics what he actually does every time in the toilet. Because many times the psychological overlay will actually not represent what the patient is actually doing in the toilet. So you have to always ask whether is this the same way that you pass urine whenever you actually pass urine in the toilet. One important thing that you have to always consider is the voiding posture. That in India, most of the women and many of the men will void in a squatting position. So you have to make a provision that if at all they have got this habit, the patient should be able to void in the same position, that is in squatting position, even in the Euroflowmetry machine. All natural processes will follow the bell-shaped curve. It may be anything in nature, it always follows the bell-shaped curve. So whatever is bell-shaped is normal. So the voiding curve should also have a bell shape, and the Qmax should be sustained for at least 2 seconds. Many times you will see an artifact that the flow suddenly goes down and comes down. So that particular finding cannot be taken as a benchmark or an correct value. It should be sustained for at least 2 seconds, and anything above 15 ml in males and 20 ml per second in females can be considered as normal. What should one see in an Euroflowmetry tracing or reading? The most important thing is the Qmax, as they call it as the Qmax, that is the maximal flow rate. I don't think so that average flow rate has got much relevance as has been depicted in this textbook diagram. What is most important is the Qmax, and which is sustained for at least 2 seconds. One more important thing is that whenever the command to void has been initiated, say here, where I put in my cursor, if the patient is taking quite some amount of time to initiate the flow, that means that he's having some amount of hesitancy. And secondly, if there is a lot of dribbling beyond this, you can also interpret that he's having a lot of post-void dribbling. So you can answer most of the questions that you have asked in the IPSS score, whether he's having hesitancy, whether he's having post-void dribbling, whether he's voiding with poor flow, whether he's straining. This is the wealth of information that you can gain out of it. Apart from that, it also helps you in treatment decision making. Like you can easily interpret a low flow, that is whichever is less than 10 ml per second. Like you will agree that less than 10 ml per second, the stricture urethra definition also says that anything less than 10 ml per second is a stricture. So any low flow, you can have these 3 possibilities. It may be a normal detrusor, an obstructed outlet, which might possibly require surgery. The second possibility might be a weak detrusor with a normal outlet. And this definitely requires something which is called as invasive aerodynamics, which we will see later on. And the third possibility, that is weak detrusor with an obstructed outlet, then naturally that will also require surgery. So it will also, the Euroflowmetry tracings will also help you in deciding whether the patient will require surgery, whether the patient will require aerodynamics before going ahead with surgery, and so on and so forth. So let's go ahead with a few normal Euroflowmetry graphs before we go to a few pathological ones. So this would be a typical normal graph. You see that the patient has voided with an adequate volume. The volume is approximately 185 ml. The maximal flow rate is 22. And you can see that it is a bell-shaped curve. The only fact that it is some amount of terminal dribbling, which is seen many times in normal females and sometimes even in males. Now we take this particular curve. As you can see that this is a 68 years old male, no treatment received so far. Sonography shows that hardly 20% of the voided volume is kept as a residue. He doesn't have any comorbidities. So if I want to interpret this graph, I can interpret the graph in some way, such a way that the patient has not initiated the act immediately. He has waited for some time, and then he has not voided with an extremely excellent flow. He has taken some time to initiate the flow, and the flow is not exactly flat, but it is an obstructed flow. So before we go ahead with what this is obviously most likely an outlet obstruction, as he's not keeping any PVR. He might be a candidate for medical therapy. But I wanted to highlight one fact here is that you have to differentiate in between a restrictive flow and an obstructive flow. Restrictive flow is a flow wherein the urine tries to pass an fixed obstruction, say a stricture, say a bladder neck obstruction, or a bladder neck stenosis. So typically what you'll see that the curve will suddenly go ahead, it will be flat and then come down. So that is called as a restrictive curve. But here you see that it's not exactly a flat curve. The ascent is very gradual. and then it's an obstructed flow. But I would say that this would be classified more as an obstructive flow rather than a restrictive flow. Any of this patient was given alpha blockers, and you see the improvement in the Qmax. The Qmax has significantly improved. The patient is voiding with a Qmax of 13.5 and he's not keeping any PVR. So just on the neuroflowmetry, you see that we can decide what is the line of treatment. Now, this is a patient who he's a 70 years old male, history of TURP done 1 year back, had short-term improvement, but again had started having voiding trouble. You see that there is some amount of post-void dribbling. And I was talking about this thing. This is restrictive. That is, took some time. The flow suddenly went up. It's an absolutely flat curve, like a box shaped, and came down. So we should not classify it that if you see like this, it is a stricture. You should say that it's a restrictive curve. That is that the flow is representative of a fixed obstruction. It may be a bladder neck stenosis, or it might be a stricture. Going a little bit further, now you see that this is a typical wavy form. Like the patient is taking all his time. You see that he has voided just 232 ml with a very poor Qmax, 4.9 ml. And the maximum flow rates are also just 4.9. But what is more significant, you see here that he has taken 3 minutes to pass just 200 ml of urine, and some hesitancy, but a prolonged void. So this is typically seen whenever the patient is having an underactive detrusor, and the commonest cause for underactive detrusor is a diabetic male. We'll not go into the details as whether it's an compensated obstruction, uncompensated, because that the invasive urodynamics will tell us. But definitely, uroflowmetry is telling us that it's this curve is a wavy curve, and that is typical of an underactive detrusor. This is one more form of an wavy curve, wherein this is again an 82 years old man. It's training at urination, diurnal frequency, 100 ml residue for the above voided volume. So this is age-related detrusor dysfunction. And in fact, if the patient is having quite a lot of symptoms, then probably the patient will require some sort of invasive urodynamics. Many times the patients will not be able to tell you as to what the symptoms are. But you can interpret it from the uroflowmetry tracings. You can see that the maximum voided volume here is 79 ml. You can repeat it again and again, and then probably you can clinch a diagnosis that actually it's a small capacity bladder because it's a bell-shaped curve. One very important feature which actually will clinch the diagnosis is that always ask the patient, what is the night frequency of urination? If he has got a small voided volume and the night frequency is say 4 or 5 times, with a very small volume, it's very likely that he is having a small capacity bladder. And the next step would be that you have to ask him to keep an voiding diary. One more thing that you have to keep in mind is OAB, but you have to remember that the definition of OAB is that you have to have 3 important things: frequency, urgency, and urge incontinence. So that might be fitting also into the scheme of the things in such cases. One more important thing, that how it helps, how the uroflowmetry tracings help. Again, see the amount of voided volume, 800 ml, plus there is some amount of residual urine. He again presents with urinary frequency. This is the same patient who we saw in the voiding diary slide, wherein you see that the patient had got frequency, urgency. In fact, he is drinking a lot of water. So again, an uroflowmetry tracing, if you go into the details, delve into details, you'll also understand and clinch a diagnosis that he is a compulsive drinker. Now we have seen the physiology of micturition. We have seen how an uroflowmetry will help us in clinching the diagnosis. We now go to the next step, that is invasive urodynamics. So let's go into some theory. What is an urodynamic study? What is the definition? Urodynamic studies assess the functional aspects of storage as well as voiding capabilities of the lower urinary tract. And the principles of urodynamic studies originated from hydrodynamics, which is used in the factory settings. Whenever we say urodynamic study, we have to be very specific when we order an urodynamic study. You have to be very specific whether you want to mention it's an CMG. You have to mention whether you want an CMG with an EMG or just an CMG. So the components of an urodynamic study are an cystometrogram, a uroflowmetry. I myself, I have been trained by Dr. Anita Patel and Dr. Dastur. Dr. Dastur was very fond of seeking for leak point pressures. particularly when we are doing pediatric urodynamics, because we want to make sure that the leak point pressures are always less than 40. Urethral pressure profilometries are almost given up, but sometimes if you are suspecting an DSD, many times you will have to use the Emg probes as well. So all in all, what are important is what I have underlined: cystometrogram, uroflowmetry, and sometimes EMG. Whenever you are doing urodynamics, particularly in patients with VUR, and you are suspecting a secondary cause for VUR, like say the patient is having a posterolateral wall, the patient has presented with an wall bladder, and you want to understand that exactly at what pressure the patient has started refluxing. So in those cases, it would be a good addition that you also include video urodynamics, that you instill contrast. You have to have an C-arm in the urodynamic suit, and simultaneously you measure the pressure as well as you see the MCOG findings as the urodynamic proceeds. What are the broad indications for invasive urodynamics in adults? I have enumerated 6 to 7 indications. We'll go one by one. So the first and the foremost indication is men with LUTS, which can't be explained with non-invasive tests, that is uroflowmetry. Example, a very small prostate, very slow flow, particularly in very young patient or very old patient who doesn't have any stricture and no comorbidities, absolute indication for urodynamics. Urodynamics is indicated in LUTS with very young patient and in very old patients with LUTS. It is indicated in patients having LUTS not showing expected response to conventional treatment, maybe post-surgery or maybe post-medical therapy. Urodynamics is indicated in any LUTs in both sexes with suspected neurogenic voiding dysfunction. I will not read out what I have given in red, because I have told you that whenever there is a Parkinson's patient, most of the times they present with dyssynergia. Be very careful before doing an TURP. CVA will present with overactivity. Diabetics, the commonest presentation is underactive detrusor. So you have to do a urodynamics in most of these patients. Men with post-prostatectomy incontinence, especially when detrusor dysfunction is suspected, that is one indication. Very common, very commonly increasing and becoming more popular nowadays. One more indication is women with mixed stress and urge incontinence, and finally women with recurrent post-surgical SUI. This is a very special group of patients wherein sometimes you may be called in to do an urodynamic study, and those are the young children. These small kids sometimes require urodynamics in these following conditions: posterolateral walls, particularly when the patient becomes 10 years of age, doing well, and now the creatinine has started going up. We want to see whether there is a problem with the compliance, problem with the capacity of the bladder. So urodynamics will give you a wealth of information in this subgroup of patients, and maybe sometimes you might have to combine this thing with video urodynamics. Patients operated for meningomyelocele when they were infants and now presenting with voiding dysfunction and having upper tract changes. You want to do something, maybe it's an poorly compliant bladder, want to do an augmentation, you might require an urodynamics before that. Extrophy patients, or even sometimes, this is the last slide that I've written, that is the age inappropriate nocturnal or diurnal enuresis, when you are suspecting dysfunctional voiding. Most of the times the diurnal as well as the nocturnal enuresis will go away, it will disappear by the age the patient becomes 5 years, and most of the patients it will go by 10. That's the reason why I said that age inappropriate nocturnal or diurnal enuresis is an indication for suspected dysfunctional voiding, is an indication for urodynamics in children. We move a little bit ahead and talk about the equipments that are required for urodynamics. Let's first go through this schematic diagram wherein it shows what are the different steps of urodynamics. Always a urodynamics starts with a free flowmetry. Always do a free flow on the uroflowmetry. Once that is done, you'll realize that what is the pattern of your flow, what you want to what are you expected to see in the actual urodynamic study, how much amount of residual urine is the patient going to leave behind, and what is the approximate bladder capacity. Why is it important to understand what is the bladder capacity? Because that will decide what is your fill rate. Because fill rate is very important whenever you are doing an invasive urodynamic study. Which are the probes that you are going to keep, and what are the functions of all these probes? So what are the pressures that you want to see? You want to see the abdominal pressure, and then you want to see the detrusor pressure. For the abdominal pressure, you will have to insert, and this is the red colored catheter that goes into the rectum that will help you in understanding what is the abdominal pressure. These are the blue lines are the Emg probes. that will help you in understanding, giving you readings of the EMG. And finally, the green line, which is kept along with the filling line, which goes inside the bladder. And the similar thing you can see here, the abdominal pressure, the vesical pressure, the detrusor pressure, which is actually a subtraction of the two pressures, and of course the free flow. Once this is done, you can keep the vesical tube, vesical line inside and ask the patient to void urine, which completes the urodynamic study. As far as the urodynamic machines go, there are a variety of machines like computerized video-based machines, Bluetooth-enabled machines, video facility, which can be used for video aerodynamics, cystometry, flowmetry, EMG studies. So depending on the budget that you have got and the applications that you want to have, you can decide which sort of machine you want to buy. The probes, the EMG probes come in two ways. One are the patch probes, which can be just attached or which can be patched in the perianal area, or you have got the needle probes. The needle probes are a little bit painful and maybe a little bit uncomfortable to the patients, but they give excellent readings, as you can see here in the left hand picture. The other consumables that you can use is either you can use a double lumen catheter or you can use an IFT for intravesical pressure measurement. So the IFT that you are going to use, actually when we are doing it in adults, we use two IFT. One would be a 6 French IFT, which is used for measuring the intravesical pressure, and the 8 French IFT, which is used for the film. But sometimes you can do away with two IFTs by using a single double lumen catheter, which measures the intravesical pressure, and the other one is for the flow. What you are seeing in the bottom is the rectal balloon, which measures the intra-abdominal pressure. Of course, you will require a few other things which are used for completion of the procedure. What is the the checklist before an invasive urodynamic test? Of course, we already saw what is the detailed history and clinical examination that one needs to do. We need to have a proper urine analysis and blood sugar estimation. Especially make sure that you have done a creatinine estimation in all the kids if the child is or the patient is the kid who is undergoing an urodynamics. Have as I told you, why we want to have an idea about the bladder capacity, because the bladder capacity will decide the fill rate, how much amount of bladder you are going to fill up. Always make sure that you have a look at the culture of the patient before you start doing the urodynamics, because you might be ending up into problems wherein you actually might end up in a sepsis if the patient is having a positive culture and active infection. A void record will help you in understanding what are the storage symptoms. And finally, this is a very controversial topic as to controversial thing as to whether we should stop alpha blockers and antimuscarinics before we do urodynamics. Actually, one school of thought is actually don't stop them, because we'll be able to understand what additional things we want to do. But one school of thought says that you actually stop them, so that actually that will unmask the pathology that is already being present. So that those are institutional preferences, but we have to know the logic and justification behind both of them. A few additional things that one has to remember is that one has to decide what is the fill rate, 10 ml, 20 ml, whatever it is. You have to decide if you are suspecting an DSD, then you have to decide what should be the whether you are going to do an EMG and the UPP or just a CMG. Always give antibiotic prophylaxis. A video urodynamics is always necessary, particularly in kids when you are suspecting an posterior urethral wall. Others, it's not necessary. Video urodynamics have got very specific indications, and you have to use them judiciously. This is what I was talking about, is the fill speed. The fill speed should be 10% of the expected bladder volume. So that is the importance why you have to do a uroflowmetry before doing an invasive urodynamics. Finally, this is very important, but an understated fact, that make sure that whenever you are doing an urodynamics, make sure that you are maintaining adequate privacy. If the patient gets an idea that somebody is watching you behind the curtain, maybe he or she will become conscious, and actually the tracings that you are going to see would not be representative. So that is the reason for that. Ask the patient in which position the patient he or she is comfortable in voiding, and that would give the maximum yield and proper results. So this is a short video which actually depicts how an urodynamic should be done. So as I told you that we generally use two tubes, and the two tubes should actually go together inside. Why I'm saying that they should go together inside, because many times what happens that the smaller tube which will actually get curled inside the prostatic urethra. And if it gets curled into the prostatic urethra, you are not going to get the intravesical pressures properly. So as you saw in the video, that as the tube was being inserted, the smaller tube was actually piggybacked into the hole of the larger tube. So in that way, both the tubes simultaneously go inside, and you should make sure when you are going to calibrate before going ahead that both the tubes are there properly inside the bladder. You should make sure that this thing is done in the most traumatic way as possible, because if you cause any trauma at this point in time, the invasive urodynamics would actually not be representative, and then the whole exercise would be a failed exercise. Now the line should be connected to the transducers, and you have to make sure that which transducer holds true for what, which is for the intravesical line and which is for the intra-abdominal line. Make sure that you calibrate them properly. Make sure that there are no air bubbles. Using a syringe and needle, you always make sure that the air bubbles are taken out. Insert the rectal catheter inside. So in this way, you will be able to measure the intra-abdominal pressures. Once this is done, the calibration should be done by asking the patient to cough. And if on coughing, the detrusor as well as the intravesical pressures show simultaneous and synchronous uptick, then that means that the calibration is done proper. Once the patient has got a normal desire and a strong desire to void, you have to remove one of the tube, that is the filled tube, and ask the patient to void on the uroflowmetry. And this is how the tracings will be seen. So in short, this is the way how you have to do the urodynamic. It should be done in absolute privacy and in almost the same way as the patient voids. It should be done in the same way. So in short, this would be the way in which the urodynamics is done. We'll go into the theoretical details as follows. The three pressures that we need to understand in the urodynamics is the P detrusor, that is the detrusor pressure, the P vesicle, that is the intravesical pressure, and the P abdominal pressure. So actually the P detrusor, that is the P det is actually the reduced pressure. So it can be calculated by subtracting the vesical pressure from the abdominal pressure. How do you interpret and tracing of a urodynamic? So for that, you have to understand that any urodynamic has got the urodynamic tracing has got the following components. It has got an filling study, it has got a storage study, and it has got an voiding study. So this particular thing is called as CC, that is command to void, or the systometric capacity wherein the command to void is given. This would be the point wherein the patient has got a normal desire. So say it is in a normal bladder, it is approximately 150 cc. So you have to make sure that you annotate it, that you have mentioned that at this point the patient had ND, that is normal desire to void. A strong desire to void is this one, wherein the patient has to void at the earliest convenience. And finally, this is the final desire to void, wherein you apply the CC, that is the systometric capacity, and you give the command to void. And after that, you have the voiding phase. If you interpret it into an physiological terms or say in practical terms, the fillings phase is wherein the patient is unaware that the bladder is being filled up. Need to go some time is the time in between the systometric capacity and strong desire or a normal desire. And now the voiding phase is the time wherein the patient says now he has got bursting feeling to go and pass urine, and now is the time where he wants to void. So these are the two comparisons. Unaware, that is the filling phase. Storage is need to go sometime soon, and voiding is now he has to go and void. The most important out of this in certain disease entities is the filling phase. Now, always all the PG students are taught that what are the components that you see in a filling phase. So the components that you have to see is first is what is the capacity of the bladder. So the strong desire would be the capacity of the bladder. Anything beyond 300 cc, that would be the capacity of a normal individual. You have to see whether the patient is having any overactivity. Now, there was a previous definition wherein they used to classify it as a sensory and a motor inactivity. Like sensory, that the patient only has got a desire to pass urine, but he doesn't leak urine. And motor means he has got both sensation as well as he leaks few drops. So first is capacity. Second is see whether he's having any overactivity. The third thing that you have to see is what is the compliance of the bladder. If the patient is having a poor compliance, then P-det would slowly start rising before it reaches the systometric capacity. So the graph trajectory would be somewhat like this. And finally, you have to understand whether the patient is having a proper proprioception. That is, at what point does he have a normal desire? If it is a small capacity bladder, he'll have a normal desire at say only 60 or 70 mm, while a normal individual will have a desire at 150 mm. So these are the 5 components that you have to decide or you have to understand before whenever you are interpreting and filling phase of an aerodynamic study. We will see what we see in the voiding phase using the 2 nomograms, but let's go into the actual picture. Now this is a typical CMG picture. The filling phase, as you see here, is showing a stable bladder because you see that there is hardly any overactivity. There is almost no overactivity throughout. Good cuff transmission, that means all the lines are patent, the lines are properly calibrated. You see that the graph lines are not going up very significantly high up, so the compliance is normal. Coming to the voiding phase, you see that the patient has voided with a bell-shaped curve. Q ura or V ura typically shows what is the voiding phase like. It is a bell curve and it is a smooth uptick of the curve, so that means that there is no obstruction. There is no, there is one, I must say that there is one after contraction, which is typically seen in normal kids as well. But most of the times in adults, you will not see this after contraction. So he has voided with say a pressure of approximately 20 centimeters of water with a good flow. So we can pass it off as a normal CMG finding. What is important that you have to interpret in the voiding graph, that there are 2 numbers that you have to remember. One is the AG number, that is the Abraham-Griffith number, also known as the bladder outlet obstruction index or the BOOI, and the calculation is P-det Qmax minus 2 Qmax. So whenever you interpret a graph, you have to go through the graphs and see what is the P-det Qmax and subtract it by the Euroflowmetry Qmax by 2. So if the figure is more than 40, definitely the patient is obstructed and might require some intervention. 20 to 40 is equivocal, less than 20 is unobstructed. And the same can be represented on this ICS nomogram. If the graph lines are somewhere here, it is obstructed. If they are somewhere here, it is unobstructed. Similarly, we are repeatedly talking about underactive detrusor. So how can we label the patient as underactive detrusor? It can be labeled using this Schaeffer's nomogram. An index for bladder contractility can be calculated from the contractility groups derived from this nomogram. So the simple formula is P-det Qmax plus 5 Qmax. So using this formula, anything beyond 150 indicates that actually the patient has got good contractility and the results after surgery are going to be very good. Less than 100 is the contractility index is low and the patient is having an poorly contractile detrusor. And the same nomograms as in AG number, ICS nomograms you can see in this Schaeffer's nomogram as well. Before we conclude, a few important Q&A questions. We will take the questions later on, but we can just go through these slides which are very representative. So this is an CMG picture. You can see that there is an overactivity here. You can see that some amount of urine is also leaked. So you see that there are 2 instances of overactivity, one over here and one over here. So typically you see that the patient is having frequency and urgency and the patient has leaked urine during the filling phase. He has voided with a good flow. So most likely the patient is having an overactive bladder or an OME. Or we take this case, you see that if you interpret these graphs, you see that this is 10, 20, 40. So you see that actually the detrusor pressures are not very high, but the patient has voided with a reasonable amount of flow over here. So what is the interpretation? So the graph shows a classical contracted detrusor with passive voiding by relaxing sphincters. There is no spleening, and this could be very common in normal women. We go a little bit forward so as to understand how this graph can be passed off as normal in a woman, but can be passed off as an underactive detrusor in a male. We go to this graph. So you see here that the P detrusor is slowly going up as it reaches systometric capacity, and see that the patient has voided with very low flow rates. you can say that the flow rate, the Qmax is hardly 5 or 6. But you see the detrusor pressure. The detrusor pressures are exceeding 70. So if you calculate the AG number, it's going to go beyond 80. So typically, without saying anything, you see that this is a stable bladder, compliance is okay, but very poor flow, good detrusor. So the diagnosis is in bladder outlet obstruction. This is very indicative of bladder outlet. And if you go into the figures of the figures that are given along with the urodynamic tracings, and you calculate the AG number is going to go beyond 70, and the bladder contractility index will also be good. Or you take this case. See, it's a good detrusor contraction, has voided with good flow. You see that the detrusor has contracted with an P date of 80, and the flow rates are also good. Some amount of abdominal straining is also used whenever it's passing urine. More or less, the EMG is silent. It's not very this thing. So probably it might be an compensated bladder outlet obstruction, because you see that still the flow rates are good. The patient is symptomatic, but the detrusor contractions are very strong. Probably if you interpret it with the clinical scenario, you can pass it off as a compensated bladder outlet obstruction. Let's say this case who has presented with hesitancy, overflow, straining. So the main symptoms in this 60 years old gentleman with interrupted flow, diurnal frequency, he is on antidepressant. So this is one history that you have to always ask in patients with neurovascular dysfunction, is whether the patient is on any antidepressants. The patient is keeping significant post-void residual urine and is voiding and is keeping this amount of urine after voiding 1 liter of urine. So let me remind you that this is a magnified image of the voiding phase. So till here, you see that we have written the CC over here, that is cystometric capacity here, and you see that these are the readings of the voiding phase. So you see that the patient is having significant amount of straining. This is the P vesicle. You see that he's using a lot of abdominal contraction for passing urine. He's using his abdominal muscles to pass urine. So, so this is an interpretation wherein actually we might interpret that the patient is using his abdominal muscle along with his detrusor muscle to pass urine. So definitely there is some amount of outlet obstruction wherein he has started going into that phase of decompensation. Let's take this case of a 65 years old man who had presented with chronic retention. That means he was maintaining a lot of urine in spite of an attempt to pass urine, and his creatinine was 3 mg/% with dilated upper tracts. The decompression was done, and the urodynamics was done 6 weeks after decompression. So what do we interpret here? If you see at systometric capacity over here, the detrusor pressure even in filling phase is exceeding 100. So typically this is a case of poor compliance because the pressures are significantly going up at systometric capacity. This is very important because this is one indication wherein it's an indication of upper tract obstruction. And that is very indicative from the clinical presentation of the patient, that the patient has presented with a creatinine of 3, upper tract dilatation. And this is the reason for that, the bladder has become poorly compliant. As well as you see that this poor compliance is at a capacity of just 200 ml. On the top of it, there is some amount of detrusor overactivity also, although he has not leaked anything. And then when a systometric command was given to void, this is the systometric capacity, you see that he has voided with good detrusor pressures and very, very poor flow. So here, after seeing this particular picture, we can advise the patient that yes, he might require TURP, but one has to be very careful about his bladder because the bladder has already got fired because of the poor compliance of this one. But if we relieve the outlet, then there is a chance that probably he might improve after surgery. Going to this case, that this is a 71 years old hypertensive, and he actually is dependent for most of his activities, which is very common in that age group of patients. He presented with retention with moderately enlarged prostate, approximately 70 grams of prostate. So what does the urodynamics show? That you see that the cuff impulse is very synergistic cuff. It is transmitted in all the 3 lines. So there is no calibration problem. But the significant finding that let us go flashback to our initial slides that we saw, wherein we were interpreting the EMG graphs in the physiology of micturition. So you see that actually when the patient is voiding, he should actually have the EMG curves, the EMG tracing silent. but you see that the EMG has gone completely out of control. So that means that there is some amount of detrusor sphincter dyssynergia. So actually, what I personally feel that if you are suspecting that a patient is having Parkinson's and the patient is having an overlying outlet obstruction because of BPH, this is one indication wherein you should use an EMG to understand whether there is only an outlet obstruction because of BPH or some amount of detrusor sphincter dyssynergia which is causing the symptoms. So in this patient, there is some amount of leak as well. So it would be not wise to do an PRP in this patient because actually it might deteriorate the symptoms of the patient. So having said this, without confusing you in further and putting forth what I want to say, I would like to have these 6 conclusions for uroflowmetry and the next set of conclusions for invasive urodynamics. So the conclusion number 1 for uroflowmetry is it is a simple non-invasive test with easy reproducibility. So it should be done in almost all patients with lower urinary tract symptoms. It is one test which every urologist must have in his clinic, primarily to exclude several other conditions rather than to diagnose a particular cause. So just for the sake of exclusion of many conditions, you should have this test done. It certainly helps in documenting a slow flow or a poor flow on the paper. It has got no relevance in just isolation. You have to always interpret uroflowmetry with the symptoms, post-void residue, and when applicable with a bladder diary. You must have realized that we have emphasized the importance in this particular talk of avoiding diary. So uroflowmetry as a standalone investigation has got very minimal clinical application. It has to be done holistically. And finally, what do the guidelines say? The AUA guidelines say that assessment of flowmetry is recommended for mainly voiding LUTS. The European guidelines say that it is for the assessment of male LUTS recommended for checking uroflowmetry, and it should be done in conjugation with clinical exam, IPSS, urinalysis, and sonography. And the NICE guidelines say that flowmetry is recommended if a male patient with LUTS does not respond to simple treatment like lifestyle changes and needs specialized evaluation. So more or less, all will agree that it is a simple non-invasive test and nothing is lost. In fact, we gain a lot by doing this simple test. As far as invasive urodynamics in men is concerned with LUTS, I must say that it is an optional test. It is not indicated in all. It should be done judiciously. Benign prostatic hyperplasia is a clinical diagnosis, but BPO, that is benign prostatic obstruction, detrusor overactivity, or underactivity, let me remind all the postgraduates that it is a urodynamic diagnosis. BPH is a clinical diagnosis. Filling cystometry and pressure flow measurements are optional tests, as I told you, that UPP and the EMG. There are very few indications where you are going to do it. Most of the times you will be doing CMG and uroflowmetry. So just to reiterate, the indications for LUTS before surgery are those patients who cannot void more than 150 ml, those patients who have got symptoms and have got a maximum flow rate of more than 15 ml per second. This is one indication of doing an urodynamics. Any patient with LUTS in extremes of cases, extremes of ages, very young patient, very old patient, an indication for urodynamics. The patient who is keeping a lot of post-void residue more than 300 ml on repeated examination, an indication for urodynamics. Any patient having LUTS with neurogenic bladder dysfunction, say stroke, diabetes, Parkinson's, it's an indication for urodynamics. You want to operate on a patient who has undergone a spinal surgery, who has undergone a radical pelvic surgery, and having an LUTS. So you feel that there is an overlap of BPH with neurogenic symptoms, it's an indication for urodynamics. And any unsuccessful treatment would be an indication for urodynamics as well. So Shivam sir, again, thank you so much for having me here today, and hope this particular talk was helpful for all.
Thank you, Dr. Arvind, for that extensive and elaborate description of the urodynamics. I think definitely our residents must have been benefited with your talk. In the meantime, I would request our residents and any other faculty member, if they have any comment or query, please go ahead. One, I think, was in the chat box. Dr. Nirav is asking whether the calibration of leads in UDS is done at 0 or at atmospheric pressure.
The calibration should be done at 0.
0, right. So it's very important that before you start the aerodynamic study, you properly calibrate it. Just see that there are no air bubbles and there are no kinks. All those things are very important. A few very important things that you said about how to pass the feeding tubes, and I think when the patient is voiding, you just remove the thicker feeding tube, and so that the patient doesn't have any obstruction because of the tubes. That's probably one of the advantages of putting two tubes rather than one double lumen catheter, which is a thicker one. So yes, anyone has any query?
One more question is there, sir, any role of UDS in suspicious retrograde ejaculation with LUTs? I would say as a standalone, suspicious retrograde ejaculation is not an indication for doing an aerodynamics.
Yes, Naveen is asking, what was in your mind when you asked this retrograde ejaculation? Because now we know that pathophysiology of retrograde ejaculation has changed. What we used to previously think that this is just contraction of the bladder neck, or which remains open, and then there is retrograde ejaculation. Probably it's not that. And we know we can also do ejaculation preserving surgery in TUR. Even if you do a bladder neck resection, still we can do it, because the most important thing is the part which is just proximal to the verumontanum. That is responsible for the ejaculation process. I think that's why, probably because the previous thinking was that about the bladder neck and all that. Anybody has any other question? We have many senior urologists in our this session. Dr. Ashok Sharma is there, and I can see many others. So if you have any comments to make, Dr. Anil Jain, Dr. Ashok Sharma, please go ahead.
I think, sir, one comment I want to make, that all the residents, as the machine I believe is going to come in the next few days to your department, you should make it a habit that before you appear for the exam, you should at least do a number of aerodynamic studies, because unless you do it, you'll not be able to interpret the results, because it's a very technically sensitive, or I must say, unless you do it, you will not be able to understand the nitty-gritties of the procedure. And then once you understand it, you will be able to interpret the investigation as well.
You're very right. I think this is very important that you do it yourself to understand the whole thing, because they're very, very small things which are very important in aerodynamic study. You mentioned about doing a uroflowmetry before, and doing a residual urine check before, and the other things like position of the patient is also very important, I think. So what do you think about how do you keep the position while filling? And definitely when you ask the patient to void, you would like him to stand. So and how do you do it in females also? So any comment on that?
Most of the time the patient is sitting, whenever he's sitting on a chair on the couch in the aerodynamic suit, whenever we are doing the filling. If the patient is very uncomfortable, then we might ask him to lie down as well. As far as the voiding is concerned, we ask the patient to void in the way the patient is most comfortable with. We ask the patient the way they void, whether they squat and void or they stand and void. Depending on that, will be, because we want it to be as physiological as possible, and the way they are more comfortable with it.
The only thing is, because it may not be possible to squat on that, because if you want to do a uroflowmetry, it may be difficult sometimes.
So we have actually those custom-made things here, which actually Anita madam used to come here. So they are very comfortable in that thing. If I will send you the photograph of the same as well.
No, that would be wonderful. I think yes, because many of the patients are used to void in squatting, and so they cannot void when standing sometimes. So it's very useful, definitely. Anything else? Anybody has anything to comment on? I think once we have the aerodynamic machine, we will even have some kind of queries, and we will just sometime get back to you. And if we have any, we will just ask you regarding that. One thing that we used to do about when the aerodynamics machine was working with us, the EMG tracing is sometimes very fallacious. It is sometimes even in a normal patient, you would see that the EMG tracing is not silent when the patient is avoiding. So it's very difficult to actually interpret sometimes the EMG recording sometimes. So what is your comment on that?
So the probe that you're using, whether the patch probes or the needle probes?
Yeah, patch probes.
Yeah. So
Surface
many
probes.
times, if the probes are actually, if the stickiness of the probe goes away, many times you will hear those voice when actually they are not supposed to. You are not supposed to hear them, or
Yeah.
they come out and then the tracing just drops in between the procedure. As against the downside of the needle probe is that the patients become very uncomfortable when they actually you prick them in the rectal area. But for the interpretation purpose, the rectal probes are better than the patch probes. So every time I'm sure that you must be using new patch probes for every this thing. But that is one way to make sure that the patch probes actually stick properly to the area where they're supposed to stay.
Right. I think that is one reason probably why it's not. So thank you very much, Dr. Arvind. So if there is no query or no question,
Sure.
Thank you once again
Thank you.
for coming to our session. And thank all other faculty members and residents who attended this session.
Thank you very much, sir. It was a pleasure.
Thank you, Dr. Arvind. Thanks a lot.
Bye.
And have
Thank
a
you and good night, sir.
Good night.
Good night.